Welcome, my friends, to the Bob and Brad podcast. My name is Mike Keenitz, and today I'm interviewing Dr. Ray McClanahan, who is a podiatrist and works at the Northwest Foot and Ankle Center located in Portland, Oregon. He is also the creator of the Correct Toes Toe Spacers, which we will talk about later on in the podcast. Today, we're talking about foot health, how to fix bunions without surgery, heel pain, hammer toes, shin splints, and plantar fasciitis or plantar fasciosis, depending upon what you want to call it. If you are watching this on our main YouTube channel and would like to hear the whole episode, you can find it on the Bob and Brad Podcast's YouTube channel or anywhere else podcasts are streamed. So without further ado, here is Dr. Ray McClanahan. So we're going to start talking about heel pain. So what are some common causes that create heel pain?
Yeah, there's probably 2 or 3 common ones, but we have to be careful with heel pain because there's outliers as well. And we could talk about some of those outliers. For instance, if somebody comes in and both of their heels hurt at the same time, we definitely talk about footwear. We set up the rehab. We talk about toe separators and some of the other things that we do. But we also keep our thinking cap on in terms of autoimmunity, connective tissue disorders, infectious disease like Lyme disease and so forth, medication side effects. I've had people take antibiotics and have bilateral plantar fascial irritation. But overwhelmingly, most people that we see are dealing with something called plantar fasciosis. For the audience, this used to be called plantar fasciitis, which suggested that the ligament on the bottom of our foot, known as the plantar fascia, was getting inflamed. Actually, before I go into that, Mike, there are also probably 2 other things that we see fairly regularly, which are a bursitis under the heel, which usually doesn't hurt first thing out of bed in the morning like fasciosis does. Usually bursitis hurts also centrally under the heel instead of on the inside back part. There's also a couple nerves that go down the side of the heel that can get irritated by a hiking boot, a running shoe, a stiff orthotic, a seam inside of the shoe. But I'd say overwhelmingly what I've seen in 27 years is probably 8 or 9 out of 10 of those people have first thing out of bed pain in the morning that gets a little bit better as they move around, sit down again at lunch, hurts again until they move around a little bit. One of my medical school professors in Philadelphia, Dr. Harvey Lamont, is not only a podiatrist, he's a dermatopathologist. So he looks at tissue specimens under the microscope to find out like what kind of disease is this? What kind of inflammation is this? And he's like a lot of podiatrists and physical therapists and orthopedists that are seeing a lot of heel pain. And statistics say it might be 40% of what we see. He did a histopathological examination of 50 of his patients, because if you fail what podiatry calls conservative therapy, which is ice and orthotics and injections and anti-inflammatories and physical therapy and maybe immobilization, you're going to get offered some kind of an operation to release your plantar fascia. And I did a lot of that early on in my career, and I'm glad I don't do that anymore. And I wish people wouldn't have that, because some of those folks never really recover. But the point is, Dr. Lamont did that operation on 50 of his patients. And during the operation, he took a piece of their plantar fascial ligament and he looked at it under his microscope. And this study is also on our website, published in 2003 in the Journal of the American Podiatric Medical Association. When he examined his specimens, nobody had any inflammation. All 50 of them had dead tissue or degenerated tissue, which was a shock and a surprise to all of us. And we'd sit around the seminars talking about, how can this be dead tissue? Because some of these people are young people. And these people are not folks that have diabetes. They're not smokers. I feel their pulses, their feet are warm, they've got hair. There's nothing wrong with their circulation until they put on the kind of footwear that we talked about at the outset of the show. And this is pivotal for anybody listening today who has heel pain, this kind of heel pain, if it's fasciosis. I'll mention a study done in 2009 in the Journal of Foot and Ankle Research, not on our website, but maybe you could look it up. A group of researchers took people's big toe and purposefully put it in a bunion. And then they took an ultrasound machine and they measured the blood flow coming into the bottom of the foot, right where people get plantar fasciosis. And when the toe was in bunion position, there was a 22.4% reduction in blood flow to the area of the heel where people hurt first thing out of bed in the morning. So it's no longer a mystery why this does not respond when we treat it as if it's an inflammatory entity. It's also no strange mystery when people get their big toe out of bunion position and resolve their plantar fasciosis. And so to your earlier point, Mike, this is an example of where we shouldn't be treating the location of the pain, because in plantar fasciosis, it's not where you hurt under the bottom of the heel. There's a muscle there that tugs on that very location, and not only tugs on the plantar fascia and the heel bone, which makes a spur, which doesn't hurt, by the way, and doesn't need to be removed. But it also, that same muscle strangulates the lateral plantar artery. And that's what that article showed. We also did a similar infrared study. A friend of ours in Spain did, where he took his infrared camera, put correctos on only his right foot, waited a half an hour, didn't put one on his left foot, and captured the heat signal of the blood flow going to the tips of his toes. Tips of his toes were 5 degrees Fahrenheit warmer. So we really do ourselves a terrible disservice to our circulation, believe it or not, with our footwear. And this isn't just stiletto high-heeled shoes. This is our walking, running, hiking shoes. And you can tell if you're doing this to yourself, audience, by pulling the sock liner out, like we mentioned. Superimpose your foot on it. If your big toe is spreading beyond it, you're probably unknowingly creating some circulatory inflow problem. So here's where, again, we try to focus on the big toe as opposed to where the patient hurts. On the other hand, like bunions, once we've outlined the natural educational material, we can treat these people, and I do treat these people. Fasciosis is dead tissue. So in addition to all the education, I will sometimes tape these people. I might do some shockwave on them. And I also inject them. And I inject them with a variety of different things. I inject them with cortisone, believe it or not, which you have to be very careful with cortisone because it can be dangerous if used inappropriately. But I use it for tissue that we don't want to be there. So if somebody comes in with fasciosis, I try to get the body to break it up and clear it out of there. And that's what cortisone does. I will use cortisone for like neuromas, which is abnormal nerve tissue, or ganglion cysts, which is abnormal fluid that we don't want. So we'll also use regenerative injection therapies, which are biological injections designed to, believe it or not, create inflammation on purpose so that the patient can actually heal their own body. And this is prolotherapy, which is sugar solution, platelet-rich plasma, where we take your own blood cells and we put your platelets where you hurt. Your platelets will make new tissue and repair the area. More recently, we're using stem cells, which are immature cells. They don't know what to become. And if you put them in the area of fasciosis, they'll start to remodel that tissue too. Beyond that, we just give it a tincture of time. We generally don't rest these people like I used to. When I thought it was inflammatory, I put them in a boot. I told them don't run. But when I took them out of the boot and I told them to slowly get back into running, their pain came right back, which puzzled me. But it also indicated that stopping activity and curing inflammation or calming inflammation didn't cure their problem. So now I show the patients in the clinic the abductor hallucis muscle strangulating their tibialis posterior artery. They see it with their own eyes. So they're not believing in a theory about this, and it's very straightforward. And that inspires them on their path to fixing their big toe position, which for the most part gets the plantar fasciosis gone. If it doesn't and they come back, then we put our thinking cap on, like I mentioned before, and start asking, is there something else going on? Is this person not well? Are they on a medication? Do they have another disease? Those people are fairly rare, but if people don't respond, we start testing a little bit more.
How long does it take before the patients see improvement?
It depends, Mike. If it's an acute case, which I always appreciate people coming in, if it's like 2 or 3 weeks they've been dealing with it, we can turn that around pretty quickly. I cringe that I occasionally meet people that they tell me they've had it 8-10 years. And for those people, sometimes it takes longer, but I'd say plantar fasciosis is probably one of the things we have the most success with turning around. So, but it's quite variable. I'd say, well, as far as I know, we get everybody well because they don't come back and we see them at the race or we follow back up with them. We actually early on had a journalist come to see us and write an article for Running Times magazine because he was also an ultramarathon coach. One of his athletes had chronic plantar, and she came to us and literally we put her in Crocs and she was better in 2 weeks. And when you treat it like plantar fasciitis, it's very uncommon to have a 2-week turnaround. So he contacted us and he's like, what are you doing? You know? And he thought it was some kind of weird placebo or some kind of woo-woo that I had done, but literally her foot was positioned naturally. She got her blood flow. She healed her dead tissue. So it can happen quicker than a lot of people think. And believe it or not, we have full-grown males weeping in the office over this problem. Because they either, some of them are in the military, and if you can't run and you can't do what you need to do, you can't be a soldier. So it's very gratifying, but it's highly variable. And as I shared a moment ago, Mike, some of these folks don't just have plantar fasciosis. They might have a leg that's longer, or they might have a weakness, or they might have a disease. So all of that needs to be factored in as well.
What do you do if someone has a longer leg?
Usually we send them for what's called a standing upright limb length inequality study. So they're getting an x-ray or a CAT scan of their femur and their tibia. And then the imaging facility sends us a report, and then we figure out, if it's a structural, meaning the bones are longer, we will use full length lifts under their short foot or the short leg to lift their whole foot, instead of doing a heel lift, which basically is like having a high-heeled shoe on one side only. So heel lift is commonly prescribed. I saw one yesterday, but the problem is that patient's hips might be symmetric and level, but she's likely going to see somebody down the road for fasciosis or ball of the foot pain because her calf muscles are going to get tight. So we do the study. Once we know what the values are, if it's not very much at all, we'll try to do it within the shoe. We also take the sock liner out of the long limb side to try to drop the long limb side some. If somebody has a large discrepancy, we'll send them to the cobbler, and the cobbler will cut the sole off their shoe, put however much material we need, and then glue the sole back on. So there's many ways of skinning that cat, but it's also critical to pick that up, because that will create arthritis and back problems and hip problems if we don't.